Thank you, Nishikant. Thank you for the kind invitation, and I wish we were all looking forward to meeting in Calcutta personally. But I guess this is the best that can be done. So the virtual format. Uh, so I'll be speaking to you about managing giant retinal tears. Uh, as we all know, giant tear is something that is defined as anything greater than 90 degrees. But usually, even a tear which is 70 or 80 degrees may behave like the same unique issues with a giant tear. So I don't think it's a degree per se. It's more theoretical. But any large tear which is got folded edges at times and has vitreous attached to its posterior edge of the base of the vitreous attachments to any large tear can have the similar repercussions. And over the years, I think what has changed greatly for this particular condition is the wide field viewing systems and perfluorocarbon liquids. For both, we need to thank Dr. Stanley Chang, because at some point before the advent of these two modalities, it was a challenge to get the giant tears flat on table, and there used to be all kinds of ways of putting retinal tacks to fix them, to lie inverted as a surgeon on the table, under the table, and set it back. And a lot of things were done to repair giant tears with limited success. So I'll take you through some videos which take you through the whole process sequence of how such tears are managed. This is a classic giant tear, as you can see, with folded edges. It is the edge has totally covered the disc and all the landmarks that we are used to seeing, and the bare choroid is seen. The remaining flap edge, interior edge is seen with the vitreous attached. So our aim with any surgery, any vitrectomy, is to clear the vitreous first, and much more so in these kind of cases where you're dealing with vitreous which is attached to edges of the tear as well as edges of the peripheral edges at times, and then of course to the retina itself. So make every effort to clean up the vitreous as far as possible, and once the tear is loosened from its all the attachments is when you can properly open it up. So that can be done using perfluorocarbon, as you can see. And you can imagine, if suppose we didn't have perfluorocarbon, how difficult it would be to get this passively to open up. There's no other way that I can think of, and we are fortunate to have this particular heavy liquid to do so. So gradually it would open up, and once you have filled it up to say the equator, you can reassess the vitreous attachments, because now you have the retina back in its place. Then do a good barrage to the edges of the tear as well as 360 to a large extent, and make sure it is well opposed, and then do an exchange. So I do a sequential exchange. I first exchange for the PFCL to air, and this requires a very patient drying up of the peripheral edges of the tear, that you can see here that I'm as the level of PFCL goes down, I'll make sure that the edges are dry. Then again, I'll double check if any areas of the laser are still required to be done, because you need to make sure all the edges are well opposed. So as you can see here also, there's all the tears, and then once the air has totally come in, you reassess for any additional laser that may be required. There may be sometimes additional tears and a bit more in the periphery that you can see. Now, I do the sequential exchange, but of course, some people like to do a direct silicone oil PFCL exchange also. So either way is possible to do based on what the surgeon is comfortable doing. Now, earlier what you saw was like a 180 degree with a turn, the flap which was turned. This is almost a 360 degree, except that the inferior part is still attached. So once again, we are removing the vitreous from the bare choroid over the bare choroid, and then trying to judge how to open it up. And you can see that as we nudge it open, then you put in PFCL to start the process of opening up and then assessing. Now, a 360 degree tear would open up, or a lesser, but here, because of the attachment inferiorly and maybe some time has passed, there's a bit of a contraction. And you can see that there is certain edges with the attachment which are stiffer. and I know that if I try to fill in more PFCL, it's going to just spill over. So I decide to make it a 360 to get a better opposition in this. So this depends on the contractions or other things that are associated, that you may sometimes need to release it from its minimal attachment and then proceed with the same steps that we discussed earlier. Now, this is a case actually I did yesterday, and this is a young kid with bilateral subluxated lenses, one eye with loss due to PVR, and he came to us with a giant tear in this eye with a subluxated lens. I first removed the subluxated cataractous lens, and behind was this fresh tear 360 degrees which had come up. Now the challenge here is, I'll take you through quickly through this, is to see that, I mean, you can see that how it is behaving. It is totally, I mean, crumpled onto itself. And I put in some PFCL because I realized that there is vitreous attached over the edges of the retina, and it's extremely difficult to get this off because there is nothing holding the retina. So I put in some PFCL. You can see triamcinolone I've used, so those crystals are floating up, and I open it to some extent, and then try to gauge from how I can remove this, and I may convert it into a bimanual by putting chandelier, because I need to hold the retina when I pull up this vitreous. Normally the retina is attached in normal detachments and you don't face this problem. We just play, but this is like a tug of war with a totally mobile retina with no hold except the disc, and was an extremely difficult situation to manage. A young child with very stiff vitreous attachments, a full 360 tear. So I'm using bimanual. I'm using a atraumatic instrument, a massager, which we use for macular holes or just to manipulate the retina. So that kind of keeps, I'm using it to keep the retina at bay while I forcibly try to use my suction to pull and release the strong vitreous attachment in this case. So this is a unique situation with the vitreous attached on these giant tears that it can create. So I persist. I had to spend almost 20 minutes with this whole maneuver to gradually release it. And twice the PFCL just went behind. I had to refill it. You can see that as I pull this again and again and again, it loosens up, and I try to cut it in between to release as much as I can, because the whole sheet doesn't come off in toto. So this process lasted a while, and the PFCL kept on going outside, and I refilled it again. As you can see here, I pulled it because it has a good hold, but as you pull more, then the flap tends to release the PFCL away. So anyways, we don't have so much time, so I put it back again, and you can see the retina is totally rotated. So I actually have to forcibly put it back by rotating it with the same massager, and then unfold the edges of those tears, and then of course do a 360. I do a few more rows of laser here because he's a young child, and maybe I've tried to remove as much vitreous as possible, but there's still residual attachment still there because there's no way I can remove it fully in this case. So these are the challenges. This is the massager that I use, and is something which I've also used in a very bad PVR case. Here again, you can see that we've removed all the edges and this crumpled up retina, and to unfold these edges, this kind of an instrument is useful, because otherwise you'll use a cutter shaft or a soft tip, and they tend to sometimes use their passive suction and keep on making small petechial mechanical damage to the retina superficially. So I find this quite useful to iron out cases like these. So how are we with time, Nishikant?
I think 12 minutes.
It's how much? You got up to 12 minutes, yeah.
So what's is the time showing somewhere, or?
Yes, it is 10:30.
Yeah.
So how many minutes?
You got another minute,
okay.
minute and a half.
So this is another case which you can see that has where I repaired a giant tear earlier, which again retracted, and with PVR changes, you can see that inferiorly there was a large tear repair, and then it retracted with the pucker. So this is something that I'm going back again. So this is a situation where resurgery is being done under PFCL. I'd remove the oil, then again relax the edges which are there, remove the pucker, re-lasered and put it back. So giant tears at times, especially inferior ones with already existing PVR when you operate, can of course lead to a redetachment at times because of the PVR inherent changes itself. And the last case I'll describe is on the time is this very posteriorly extending giant tear with vitreous attached, as you can see, with some hemorrhage which had occurred and a macular hole also. So once again, here the aim is to free the retina, to release it, and then of course stain the ILM and remove it over the hole. Now, because the tear here is very posterior, you can see it's hardly 3 or 4 disc diameters. The edge is there from the macula. So when I peel the ILM, my aim is that I'll also peel it right up to the edge of the tear, because otherwise the contraction from the ILM, the retina already has a bit of a contraction due to the tear itself. So I did a peeling right up to the edge of the tear, and then of course relaxed it on the edges, and then did a laser. As you can see, I'll do much less laser rows because there's very little retina to play with on the temporal side of the macula. So these are slightly different situations that I thought I'll show you the challenges which typically the giant retinal tear cases come up with in the time span that I have to speak. So thank you very much, and maybe we are free to ask questions or discussions or whatever.